Surgeons today are beginning to reconstruct amputated limbs by implanting prosthetics directly into the skeletons of patients. In this conversation, I spoke to world-leading osseointegration surgeon Munjed Al Muderis about the new technology that's replacing external prosthetics and allowing amputees to move and feel again. I'm Shane Farnsworth, and this is the Escape Sapiens podcast. These conversations are supported by the Andrew von Braun Foundation. If you enjoy what I'm doing and want to support me, you can do so by subscribing, liking, and sharing this content. And now, here's Munjed Al Muderis. I hope you enjoy.
Escape Sapiens.
So let's jump into what you actually do as a doctor. So let's get to the real sort of meat of the conversation. What is osseointegration, and what does it do better than traditional prosthetics?
Well, osseointegration is an innovative technology. It is osseointegration application for amputees is a newer technology. The word osseointegration meaning the bond of metal and bone. And this started in the 60s with dental implants. And it became very popular around the world nowadays, where there are millions and millions of dental implants inserted in teeth very successfully. Mind you, the tooth and the mouth is the dirtiest part of our body, okay, and has the worst bacteria that you can think of. So it does work. The application of osseointegration on limbs and amputees started in the early 90s. The first patient was in 1990, where the son of the inventor of the dental implant is an orthopedic surgeon, and he magnified a dental implant, make it a mega dental implant, and insert it into the femur of a bilateral amputee. And that worked. The lady walked with an osseointegration device for 24 years. Mm-hmm. I was fascinated about the idea of giving amputees some sort of normality, restoring their mobility back and giving them hope and making them functional in the society again. Especially that the technology that they use, that I've seen since I was growing in Iraq, is a socket-mounted prosthesis, which is a technology that involves encasing a socket, a hard socket, used to be made of wood. In the last 40 years started becoming of fiberglass and carbon fiber, but it encased the whole residual limb and suspend an artificial limb, an artificial leg from there, or an artificial hand. This technology has not changed over the last 600 years. In 1529, Per Ingvar, Andreas Pare, if I do apologize to him if I pronounce his name wrong. I think his name is Ambroise Pare. He was a French naval officer, invented the socket-mounted prosthesis in 1529. And since then, we've been using the same technology to this date. It must be something new. There must be something revolutionizing this idea, because obviously it's been going on for that long, but hasn't shown any significant changes. The prostheses have changed. In the past, there used to be just a stick, and then it became a mechanical limb, and now it's my electric limb that has sensors and has even motorized limb. But the interface that hook up the prosthetic limb with the body has not changed. So I was fascinated about finding a solution. So what I did in 2010, in 2008, I went and studied the technology in Germany. And the Germans have a different theory about osseointegration, where it's a press fit, but they used where it's similar to a hip or a knee replacement, where instead of a screw fixation device like a dental implant, the dental implant is screwed in. Mm-hmm. While the Germans believed in hammering in something that shoved in inside the bone and sticks, and then the bone grow on it. That made more sense to me, because that's what I do as an orthopedic surgeon in my training. we put hips and knees, and that's how it works. You jam it in and the bone grow in it. So the Germans were doing that, but they were using a different material, which is chrome cobalt, not titanium. So it's not biocompatible as much. So I came up with an idea using a titanium material, using a press fit technology, merging the two. And historically, the Germans and the Swedes were competing about osseointegration, okay, and they were doing niche kind of 5 cases a year because it's very limited number for many reasons. One of the reasons is that it's 2-stage surgery, 18 months rehabilitation period, and people have to go through multiple very slow process of weight bearing. So a lot of patients don't have time for that. So I came up with the thought that what if we make it like a hip replacement? So I merged this technology, modified the technique, modified the implant design, and came up with a design that is similar to a hip replacement, that provide very rough surface, can be inserted easily, okay, by a trained orthopedic surgeon in a short period of time, and make it one operation that the patient get the implant and then start walking.
Okay.
And that was the creation of my approach to osseointegration in 2010.
So just so people understand what's going on. So let's say, for example, I came with an above the knee amputation. What would the procedure look like? So you would insert a titanium rod into the larger bone there in my upper leg, and then how long would it take before I could walk on that?
Yeah. So the process that I developed will involve opening the, for example, you have an above knee amputee. You open the stump, refashion the soft tissue, the muscles, the subcutaneous tissue, the fat, open it all up until you get to the bone. You get to the bone, you open the canal in the bone, you ream it inside, bore it to fit the optimum size for the implant, and then you insert the implant in there, and then you reorganize the muscles and the soft tissue around that implant, and then you organize the nerves, sometimes with what's called targeted muscle reinnervation, where you reinnervate these muscles for 2 purposes. 1, to pain manage, and 2, to utilize these as an amplifier to create some sort of functionality for the myoprosthetic limb in the future. And then you connect that implant through a small opening in the skin to a prosthetic limb.
So there's an actual open. It's not closed off. You directly connect.
So you will have the implant in the bone inserted, sealed, and then you have muscles around it, organized to operate it, and then you have a connector that percutaneously that perforate the skin and connect into a prosthetic limb. And that will operate a prosthetic limb, myoelectric limb. This technology, with the patient like a piece of metal sticking out of the leg, okay, and the patient start standing up the day after the surgery. And they increase the loading, depend on the loading protocol, but they get fitted with a prosthetic limb as early as 2 weeks after the surgery, and then they walk with 2 crutches for 6 weeks, 1 crutch with 6 weeks, and then unaided after. So I compacted the rehabilitation protocol. Number 1, I made it, instead of 2 or more surgeries, to 1 surgery, and number 2, the rehabilitation protocol went from 18 months to literally 2 weeks. Okay, not dissimilar to a hip replacement. 6 weeks in the vast majority of cases, not dissimilar to a hip replacement. And the patient will gain their independence. Just to be clear, this is not an operation to relieve pain. This is an operation to give people mobility back. This is an operation that will allow the patient to have higher level of mobility, more confidence. It will eliminate the socket-mounted prosthesis problems by less interference with the skin, because people with the socket, they get silicone allergy, they get irritation, they get chafing, they get blisters, they get friction, they get excoriation, and they get sweating, they get smell. All of that happen with the socket-mounted prosthesis. And this is one aspect from the contact. The other aspect is that human beings, especially females, they have diurnal changes. In the morning, the size of the leg is much smaller than at the end of the day. It swells up. So in the morning, the leg is roomy inside the socket, because the socket is hard, fixed, made out of not flexible material. And then by the end of the day, you can't put it on because your leg is too swollen that doesn't fit in the socket. So that will be eliminated. And the third thing, which is very important that we didn't know about, these people get some sort of feedback. They could feel carpet, they could feel tile.
This is people with the implant.
With the osseointegration, because people with osseointegration is directly attached to the skeleton. And the nerves, when we reorganize them, and they start recognizing the sense. So you tap on the leg and they tell you where you tapped. When
As
they
in
walk,
along the limb, they can actually distinguish.
They can distinguish and they can identify the ground. So this is very important for people who are going back to work, because an amputee with a socket cannot walk into a dark room, because they have to look at the ground when they walk, because they can't feel the ground. It's like you are on a hover mat. Okay. While with osseointegration, you feel the ground, you feel the vibration, you feel the feedback from the ground. So they can walk with their eyes closed, and we've done tests on that. They can walk into a dark room and they don't need to look at the ground. So that allows patients to regain some sort of occupation that they were prohibited from doing as a socket user amputees. So these are the three main things: is eliminating the socket mounted prosthesis problems, controlling their mobility and fit better, and giving the patient an osseoperception or the proprioception back, which is the sense of the ground. That's the advantage of osseointegration over the traditional socket mount prosthesis. Now, would I say that osseointegration is better or superior technology? Definitely not, because that comes with risks. The surgery, you need to have surgery to have this procedure. There is a risk of infection. There is a risk of infection with the socket from the skin friction, but there is a risk of infection where you have a piece of metal sticking out of the leg. That risk of infection varies depending on the individuals, depending on how heavy they are, if they are smokers, if they are diabetic, if they have vascular disorder, depend on their hygiene. There is a risk of granulation tissue. There is a risk of...
What's the granulation?
Which is overgrowth of tissue around, and that can be irritating. There is a risk of bleeding, gushing. If you are on blood thinners, you gush blood from it every now and then with activity. But all these risks are reasonable. And when you weigh the benefits versus the risk, that's why when you seek osseointegration or when you seek any medical advice, you don't go to a computer and tick boxes and then you get your operation. That's why you have to sit in front of a clinician, or in my case, you sit in front of a panel of clinicians with multidisciplinary approach. You will see myself, you see a group of surgeons, you'll see a pain specialist, you'll see a psychologist, you'll see a prosthetist, you'll see a physician, you'll see a physiotherapist, you see a nurse specialist. All these people have a say on whether you're a yay or a nay. Okay.
So who is a candidate then? Who is the if you could paint a picture of the ideal candidate for this sort of a...
So I can give you two scenarios. Okay, and to the inexperienced eyes, okay, one will be the best candidate and the other will be the worst candidate. Okay, so the first scenario is a young Paralympian above knee amputee, a male with a very good residuum, very healthy, no medical condition. Okay, won 7 gold medals in the Paralympics. Okay, and want to participate in the next Paralympics. That's one candidate. Okay, the second one is a diabetic ex-smoker, a person who's in a wheelchair that cannot get to the kitchen and to the fridge, and all they want is to have some dignity in order to walk with their dog, or walk around the house and get to and get rid of the carers that they have to have, and gain some independence. Which one would you choose as a candidate?
From a risks perspective, I would say I would choose the Olympian. From a regaining life perspective, I would choose the one who just wants to walk and just walk their dog.
That's very good. Having said that, from a risk perspective, I would choose the wheelchair-bound patient.
Why is that?
Because the Paralympian has unexpected expectations.
They have very high expectations of what they're going to do.
They have very high expectations, okay? They will never get their leg back, okay? They will always be above knee amputee, okay? This will not give them their leg back. And what they're doing now is too good. So giving them the osseointegration will expose them to unnecessary risk.
I see.
So that's why, from
So
a risk perspective,
the trade-off isn't worth it.
Yeah. So weighing the benefits versus the risks outweighs the benefits by miles. Okay, and that's why I said, from a risk perspective, the Paralympian is much riskier.
I see.
Okay, because I will add little, possibly, to them, but I would give them a chance of having a lot of problems.
For example,
If it doesn't work, if they get infection, if they have an infection that requires them to lose the rest of their leg, touch wood, nothing, that doesn't happen often and hasn't happened to us. Okay, but this is a very minor risk, but does exist. Okay.
So can patients load can they run, for instance? Is it strong enough?
So I used to say no running before, okay, but now I ask them not to run for the first year, and because we have a lot of people that are Paralympians, and they became Paralympians after we operate on them. So I have several patients like Mikul, like people that David Watson. This is public knowledge, and there is no breach of patient confidentiality here, because they won Paralympic medals, and they won Invictus Games medals, and they went public about and there are stories written about them.
So when you're sitting there and you're watching the TV and you see them cross the finish line, like, what does that feel? You've constructed that leg.
I mean, look, it's a good feeling of satisfaction. But what I'm more interested in is looking at the satisfaction that their family have. Okay, because when a child look at their dad for the first time walking after they've been wheelchair bound, mind you, a lot of these Paralympians, a lot of these Invicta Games winners were wheelchair bound when they came to see me. So by being part of their journey to walk again and hold their hands with their children, that is the biggest achievement. Okay, that's what satisfies me the most. Okay, so back to the story about the risk.
Yeah.
Okay, so if you can manage to get a patient out of a wheelchair, cure their diabetes, if they are type 2 diabetics, allowing them to lose weight and being engaged in the society, then that is a much lower risk. Despite that, the ill-experienced eyes, and even some clinicians criticize that heavily. Okay, I can openly speak to you about a patient that I treated where the clinicians thought that this patient should be doomed, wheelchair bound, and let that patient go. And despite that, this patient was in her 30s. But she had medical problems, okay? And she was a very high-risk patient, but she was wheelchair bound, okay? She was properly assessed by the panel, by the team, multidisciplinary, and was found that we can give her another lease on life. with not much, risk taking, because we could optimize a lot of things that were overlooked by other people. And as a result of that, this patient regained mobility, returned back to high impact, high functionality, not high impact, high functionality, and very and become very happy with her life. Okay, and that was a risk, despite that we faced extreme criticism about taking on this patient. But because we measured the risk, we had a multidisciplinary approach, we had a very calculated approach toward the risk, the patient had full understanding and had full psychological assessment, ticked all the boxes that we could tick, okay, and look at that patient with a different angle, and believe that we can give this patient some sort of functionality and not give up on this patient, okay, and just deem that patient, become the judge, the jury, and the executioner for this patient. Every person deserves another chance, okay, and I'm not a person that would call myself, I would make miracles. I'm just a clinician that utilize my knowledge, my expertise, and my team expertise to the best interest of the patient. We're not trying to give patients false hope. We're just trying to maximize the benefits of the doubt and maximize what the medical fraternity can provide for these patients without causing them harm or minimizing the risk.
One of the things I find amazing about what you said just then is that, okay, you're able to move this surgery into one operation. And from the perspective of scaling and getting these sort of procedures to a large number of people, that's obviously an amazing thing. But what I'm curious about is, I know that for tooth implants, often if the patient has not had a tooth there for some time, the bone will deteriorate because it hasn't had pressure on it. Do you have to ever do bone implants prior to doing the surgery, or do you need to strengthen with bone implants? How do you manage that?
So this is very, very, very important question, very good question. And that's why when I answered the first question, it depends on the protocol and depends on the individual. So if you have a healthy young individual who lost their limb 2 years ago, okay, and they're walking with a socket, but they have problems with the socket, we would offer them this surgery and they will be on the fast protocol. Okay, because their bone, we assess the bone quality, we do DEXA scan on every patient, we do CT scan on every patient, we do x-rays on every patient, and we assess their mobility, we assess their functionality, and we assess their bone density. All of these measures are taken into place, and then based on that we decide the protocol. So if a patient hasn't deteriorated with their bone, we load them quickly. If the patient is osteoporotic, elderly person that has not walked for 20 years and they want to have a chance of walking, they will go through, they still single surgery, but they will go through a very slow loading protocol until they build their bone, okay? Because they are higher risk of fracture. We don't implant bone, well, on routine basis, we have done that on special occasions, but it's not one suit fit everybody. Again, it's not a vending machine where you tick on the numbers and an operation comes out. That's why we are a team of multidisciplinary members, where we approach every patient individually, case by case, assessed, and then evaluate what is best for that particular patient.
I see. So rather than having to do everything in the surgery through rehabilitation after the fact, you can actually get, okay, that makes a lot of sense.
Yeah. So the rehabilitation represents significant portion of the process, and definitely it's a very important part of the process. If you don't have a rehabilitation, you don't have a process at all. Psychology, management of pain, all these are essential parts. So the elements, so you have the surgeon is just a single link in the chain. But you don't have a chain unless you have all the links working together and acting together. And everybody is equally important in the preoperative assessment, in the intraoperative care, and the postoperative care, and the continuation of care afterward on long term. So it is a process. It is very rewarding. Does it work all the time? Definitely not. But I can speak with confidence that mobility-wise, we have managed to help the vast majority of patients. Pain is a different story.
Okay.
Patients who lose a limb, they amputate bone, they amputate muscle, they amputate tendons, soft tissue, including nerves. When nerves are amputated, they go haywire. They develop neuromas, they develop phantom limb pain, they develop phantom limb sensation. That happens as a result of the amputation. That does not happen as a result of the surgery. That happens from the moment the nerve gets injured in the first insult, the nerve start acting funny. To manage that, science has not got to a definitive answers. We still have major issues with management of pain. And when you see that there are 100 modalities of treatment of one problem, you would know that there is no one fix.
But do these sort of operations actually help at all?
So what we do, from the pain point of view, we use a multimodal approach. That's why we have a psychologist that works on the pain. We have a pain specialist that works on the pain. We have a surgeon that works on the pain. So it goes from giving a patient simple tablets to intravenous medications to stimulators, electricity like RF signals, to dorsal root ganglia stimulators, to pain stimulators, to surgical intervention where we cut the nerves, to re-innovate other parts.
So what does that mean? What is re-innovation?
So targeted muscle reinnovation is a technology where we utilize to, number one, get rid of the neuromas that forms at the end of the so when a nerve is cut, the ends get stimulated, think that the nerve is injured, I need to grow. So the nerves start growing. And when the nerve grow, not in a conduit or not in a tube, it will sprout out like a fungus or like a cauliflower, and forms a cauliflower that's very sensitive called a neuroma. And that neuroma can create significant problems for the patient pain-wise. So what we do, we cut that neuroma, and then we found a small nerve that innervate a muscle, and take that's attached to the muscle, and then get that nerve and plug it into that nerve and create another conduit or another tube for that nerve fibers to grow into and innervate that muscle.
How fiddly is this in the operation?
It is very fiddly. It is very fiddly, but it's a technology that has been developed, okay, and we have modified and we continue to work on to find a job for the nerve to do. And the theory behind that is to create a job for the nerve so it doesn't cause pain.
This is maybe a really stupid question, but how do you actually attach one end of a nerve to another one? You obviously don't tie them.
We repair them. So what we do, in order to attach one end of the nerve to the other, we carefully and meticulously repair the nerve endings together, and then we wrap the muscle on the remainder of the nerve, so the nerve will be engulfed and encased by the nerve and the muscle. And that way, this nerve that has been amputated will sprout out. Instead of sprouting out like a cauliflower, it will grow inside the nerve and inside that muscle and innervate that muscle, and it will give it functionality. So by doing that, the theory is to inhibit or limit or reduce the chance of the phantom limb pain, reduce the chance of neuroma formation, and reduce chance of phantom sensation. So
and perhaps also get function out of the muscle.
Well, that's one primary reason, is to reduce the pain. Does it work 100% of the time? Definitely not. Okay? It works in certain percentage, and we don't have enough data, we don't have enough information to give you the numbers. Okay? But we're hoping that this will carry some hope for the future of phantom limb pain management. That's one reason of doing it. The second reason is that, especially in upper limb, by doing targeted muscle reinnervation, we provide this reinnervation where the brachial plexus is cut. We shift the nerves to the chest wall and use muscles that are not utilized anymore, reinnervate them, and they become amplifiers for signals. So the nerve that supplied the thumb will go to the chest wall, and you ask the patient to move the thumb and the chest wall move. Now, what's the advantage of that is that you can put sensors on the chest wall very closely and very dedicated to these nerves, that the thumb, the index finger, the hand, the wrist, each one will be dedicated in one of the muscles of the chest wall that are not utilized anyway in the amputation, okay, because it will be useless otherwise. And these signals will be transmitted to operator myoelectric prosthesis because it's amplified. So instead of haphazardly getting a myoelectric prosthesis attached to a big space, you're trying to get a signal from a big, large area. You're getting the signal from a very focal area, which will be very targeted, okay, and very carefully selected, and that will have more accuracy in operating a myoelectric prosthesis.
So you regain dexterity. And is this all internal then? So because you have...
It's all internal.
Right, and so that's the benefit, right? Because you have the osseointegration already happening, you already have the connection from inside to outside, now you may as well also connect up the nerves internally. I see, so that's the benefit.
Again, this is a working process. We are developing this and trying to get everything within the implant, within the prosthesis is a job that we are working on, because it will involve a lot more regulatory processes and pathways. So at the moment it's mixed, but the aim is to make it all internal for the future.
So can we take a step back? So how many of these operations have you done?
Depends on what
question. So let's just say, for example, above knee amputation.
So total osseointegration, we've done over 1,000 now. And there are coming close to 2,000 around the world.
I see. So from 1,000 patients, what do outcomes look like in terms? Let's look, for instance, at infections.
Yes.
So what sort of infection? What are the rates? What are the numbers?
So we published a landmark paper in Journal of Bone Joint Surgery in 2015, I think, about the rate of infection or safety of osseointegration. It was published in JBJS American, and that was the landmark paper that we put our classification of infection, because before that people didn't understand what is infection. People have increased seepage, they think it's an infection. People have blood, they think it's infection. People have big redness and swelling, they think it's infection. People have fevers and being unwell, they think it's infection. So we thought that, hang on, this is a new technology, we need to classify it. So I created a grading system for infection from grade 1 to grade 4. Grade 1, which requires oral antibiotics, which is just soft tissue infection, superficial infection that involve redness of the skin that can be treated by oral antibiotics and doesn't need intervention, okay? And then grade 2, where you have deeper soft tissue infection, where the deeper layers of the soft tissue is infected and people have discharging pus and more purulent discharge and more pain, and can be treated with oral antibiotic or intravenous antibiotic or with surgical debridement. Then you have grade 3, where the bone is involved, and you have periosteal reaction, osteitis, inflammation in the bone, and that is more deep okay, involving the bone itself, and that can be treated again by any modality, including surgery. And then you have grade 4, where the implant fail as a result of the infection, which is a catastrophic failure. So this was the grading system, and from the grading system, the grade 4 was very rare.
Well, what sort of numbers from 1,000?
Look, I mean, the numbers, we didn't have 1,000. Now we're writing another paper about the 1,000, okay? And that will give you more accurate, because there is a paper about infection particularly in that. But from memory, the grade 4 was like 2% or something like that. And the grade 1 was around 34%.
I see. And in between?
And in between, you have 5% for bony infection, and then maybe 15% for deeper soft tissue infection. I can't remember the exact figures, but this is overall what I see day in, day out. Okay.
So can I? So 34%. That's superficial. That's something, just oral antibiotics. You can deal with that.
Yes, superficial infection that doesn't require an invasive procedure.
And how does that compare? For example, you said, for instance, that people who have the fitted prosthetic, they will also sometimes get skin infections. How does that compare to those sorts
So
of...
for a superficial infection is comparable, and that is very interesting. Okay, so we've done another paper. So for because there is no implant inside the bone, so you can't get the bony. I mean, people do get bony infections with a socket as well. People do get ulcers. People do get bony infections with the socket. But the data is very, there is not enough literature have been written about it. You need to understand, amputees are the too hard basket for medicine. And majority of amputees are not treated by clinical physicians. They're treated by prosthetists and physiotherapists.
I see.
Because surgeons don't treat amputees. Throughout our training, if I tell you the amount of hours we spent on studying about amputation was very small. Okay, there was one lecture basically, and then when you come and do amputation to a surgeon mean failure.
I see.
Okay, and a patient comes in when they get the amputation. After the amputation, you see them when the wound heal, and after the wound heal, they go to the prosthetist, and you don't see them again. So what I'm trying to create is a completely different scenario where you move this cohort of patients back to the medical field, and you follow them up, because these patients will continue to be your patients. As opposed to when they use a socket, you don't fit them with the socket, the prosthetist fit them with the socket, and you don't see them unless there is a complication. And if there is a complication, they come back to a surgeon or any surgeon. Okay? And because of the phantom limb pain, and because of the pain that these patients have with amputation, they are always, unfortunately, starting for a very low point, because they are physically, mentally, and psychologically traumatized. So you're starting with a very difficult cohort of patients that sadly not many people are happy to deal with, because they are complex patients.
Okay. I want to get onto the mental impact of having one of these implants in a little bit, but can we go then to the other categories?
Just before I go there, periprosthetic fractures, because breaking around the implant, okay, is a big deal, okay, and it's in the vicinity of 5 to 7%. That's even higher than serious infections. But when you look at the literature, and we did a comparative study, we published about it. I mean, mind you, what makes us very strong is our publication is very big. And we publish about everything, the good, the bad, and the ugly. And that's how, because we believe that this should be the existing technology for a wider number of amputees. Okay, and this should be well-established technology that is available, similar to what happened in the hip replacement in the 60s. Okay, where it was heavily criticized, very ostracized, and then look at it now, it's the standard. Similar to what happened to the dental implant, again, in the 80s, okay, it was never acknowledged, and now it become widely acknowledged.
Well, can I ask you, so with dental implants, how do the infection rates compare with what you're doing with amputees?
So again, that's a very good question, and it's on par. It's very comparable. And dental implants, they do get infected. And I don't have exact numbers from the literature, but it's very clearly stated that infection rate is significant.
And why?
But it's manageable.
But why is it? So you mentioned at the start that the mouth is one area where you've got huge amounts of bacteria. It's I suppose a dirty place to have this sort of interaction. So why is it that they're so successful? Why is it that it's possible to do this? Because to my mind, it sounds crazy that you can have an open wound and
so dirty areas in the body are orifices. Okay, so you have the mouth, you have the urinary tract, you have the bowel, the anal sphincter. All these are dirty. The anal sphincter, as a matter of fact, factually speaking, is cleaner than the mouth. Okay, because of the nature of bacteria. Okay, they're more vicious in the mouth. Okay, and that's why if a cat, for example, a cat mouth is very dirty, and you hear that cat bit the owner and then the person lost the hand. Okay, because I'm treating a cat bite now in the hospital with severe infection. Okay, that we had to do surgery to just try to save the person's hand. Okay, so why is it successful? Now it's all goes down to the technique. If you provide a solid interface between the bone and the implant with no movement and no room to go, and you have a proper, stable, soft tissue coverage, the bacteria doesn't have a place to go to. So the infection risk will become lower. That's why with modification of the technology of osseointegration in the limbs, we minimize the soft tissue. Okay, that's why in more obese patients, the infection rate is higher. Okay, and when with using a more robust osseointegrated implant, that reduce the infection rate dramatically. Okay, same thing with the dental implant. They moved into stages, and they were doing 2 stages, 3 stages, and now they're doing it in 1 stage. Again, so evolution has occurred in both the dental industry and in our field, and I think that will help people by having less number of operations, less chance of infection, less chance of intervention, and less chance of complication, basically. Back to the fracture, okay? So 5 to 7% per prosthetic fracture happen with osseointegration, okay? And when we looked at the literature of socket users, it's exactly the same number, okay? So
a socket user is a hip. Oh no,
they're
hip.
Traditional socket prosthesis.
Oh, I see.
People use this traditional socket prosthesis. So when you look at the superficial infection, is not different, okay? But we don't have enough data about what percentage of bony infection that these people have, okay? Which is not insignificant. What I'm trying to say is that we are dealing with very complex patients. We are dealing with very complex pathology. We will not grow a leg back, okay? It's much easier to treat arthritic hips or knees, okay? With arthritic hip, it's much more guaranteed outcome. You get a hip replacement or a knee replacement, success rate is in the high 90s, okay? And people are very happy. Majority of these people have no psychological issues, no mental issues, okay? And their disability is just because they develop arthritis, and you immediately give them their mobility back, okay? And they are the happiest patients, and relieve their pain. Pain is a big deal with arthritis, and it changed their life dramatically, because when you take the arthritis away, you do the hip replacement, you do the knee replacement, you do the ankle replacement, and mind you, we do a lot of ankle replacements now, okay? And this is the future, because until now, a lot of people with ankle arthritis go to the doctor and they get it fused. We are philosophically against fusion for the vast majority of patients. If we can replace an ankle, we would replace it, because there's nothing better than restoring mobility and relieving pain.
What about in the spine? Because you hear about people who have fused spines who have lots of problems. Is that something that's ever going to be possible, or?
I'm not sure, because I specialize. This is outside my specialty, so I can't comment on that. But definitely, any joint is designed to move. The joint is designed to move. The joint is not designed to be stiffened. Okay, so it makes a lot of sense if you replace the ankle. I mean, ankle fusion so far is the golden standard treatment for ankle arthritis, and I think this is changing very quickly. Okay, we changed that in hip replacement, we changed that in knee replacement, and the next is ankle replacement, and we have very good successful outcome from ankle replacement. But the point is, these patients, you give them their mobility and you give them pain relief. What you can't do in osseointegration.
I see.
With osseointegration, you give them their mobility, but you may not give them pain relief. And that's why you have a certain cohort of patients that will continue to have issues. And that's why it is very important to have proper education for these patients. Proper, thorough consultation to manage expectations. And that's why when I told you about the two scenarios, okay, the scenario of the athlete is much harder to treat than the scenario of the wheelchair-bound patient, okay? And patients can be optimized for surgery. Patients can be minimized with their risks, okay? But what you can't guarantee is giving a patient a pain-free osseointegration surgery, because pain is pre-existing. The vast majority of patients that come to us asking about osseointegration do have pre-existing symptoms with phantom pain, phantom sensation, and that's why we're very careful with documenting everything, and because people forget, okay? And sometimes, and it happened before, and scenarios where the patient says, I lost my house, I lost my wife, I lost my company, and I developed regional pain syndrome. No, sorry, sir, okay? You came to us with this problem, okay? And we did osseointegration, but we didn't relieve the pain because we could not relieve the pain, okay? So, and that's why when we go back to the patient and say, hang on, but in your initial inquiry, you told us about the amount of pain that you have, and you're telling us exactly the same symptoms. It is a bit better, okay, but it's not gone, and that's because we started with this. We can work on that, but separate to the osseointegration surgery. And that's very important to understand from patient expectation point of view, that this is not a pain relieving operation. This is an operation that would give the patient better mobility.
Can you give some examples? So, for example, let me ask, do you have any stories of patients in particular that you're proud of working on, that really stick in your mind, that where you've really seen this has really worked, this has really done a great job for this patient? I mean, you've had 1,000 patients now, so there must be many. But
look, I go through a lot of criticism. I go through a lot of attacks. I go through a lot of negativism in my life. And what keeps me going is my patients. The vast majority of my patients I'm very proud of. The vast majority of my patients are proud of me. And the vast majority of patients, make me do what I do. And every time I have a dark moment, it's amazing how you have a message on your phone or a Facebook coming up, or someone pick up the phone and call you and say, thank you very much for doing this for me. You gave me my life back. So the vast majority of my patients, I'm very proud of being able to serve them and being able to be part of their journey and their life. Okay, and I will continue to do what I do despite the odds. Definitely, I have failed some patients. Definitely, I have disappointed some patients, and I'm not perfect. And there are certain circumstances where we treated patients there that we couldn't help them. We couldn't solve their problems, and we were below their expectation. And that's again back to the point where I can only improve on the pre-operative and assessment time, where education about expectation for the patients, because that is sometimes, and I always tell my colleagues and tell my people that I train always, go through the mundane process. Okay, even if it's as bright as the light of the sun, that this patient require that, you need to go through the mundane process of ticking every single box, because you never know, what you would be missing. Okay, and if you do that and you go through your checklist, it's like flying a plane. A pilot has to go through that checklist in order to have a safe journey. And with medicine, unfortunately, it's not as good as flying a plane, because you're dealing with a machine, you're not dealing with a human being. Because there are elements that you face where the machine doesn't change, human being can vary, emotions can intervene, other circumstances can intervene, okay, that can alter the course. And ultimately, sometimes, you get patients who are extremely unhappy and extremely dissatisfied, and then you take them through the journey and they become your best mates. Okay, but they have to go through the journey, and it's all about trust, and it's all about good communication, and it's all about having your faith in someone. And then the opposite, you get sometimes where patients are very happy and very easygoing about everything, and then everything changes. And when that happens, you need to respect that. And you need to empower the patient to make their decision to move away. Okay? And if they decide to do that, you have no control on it, unfortunately. And sometimes, it's for the better good for them. Okay? And sometimes it's not. Sometimes you feel inside you, and I see that, where patients have, decided, I don't want you to treat me anymore, and they've gone elsewhere, and you see that, and you say, look, you're going somewhere where you will not get the best, okay? But you can't. You just have to let go, and it's like a divorce, You have to back off and take it on the chin and respect the patient wish. Ultimately, I am here and we are here to serve these patients. We're not here to control them. We're not here to dictate to them what they have to do. All what we can do best is to empower the patient to make the right decision for themselves.
Well, can you tell me about some of the exciting developments when it comes to, for example, having prosthetics that actually move and can do what people want and give more back to a patient, rather than just having sort of a dumb prosthetic, something that actually works and moves for them?
So I can show you certain examples of our patients that have had this technology and what this have given them back. And you can see the control that these people have on their prosthetic is amazing, because they wouldn't be able to achieve that with basically the socket-mounted prosthesis and the the traditional prosthesis. And you can see, like, these are examples. This is only a few weeks after the patient was fitted with the prosthesis.
For those who are just listening, there's a gentleman with two hand prosthetics, and he's moving them around as though they're his own arms, essentially.
And and this is in Australia, but then when you look at it, this technology can be translated not just to Australia, but can be translated all around the world, even in developing countries.
See, this is something that I really want to ask you about, because so you said you've done something like 50% of the...
So this is a similar prosthesis, but 10 million times cheaper, okay, in Iraq, where a patient can still operate the same technology, do the same thing, okay, and this is with one of there is a talented Australian, he was an Australian of the Year, who have invented a myoelectric prosthesis, okay.
What's his name?
I don't know if I'm allowed to disclose his name, okay, but you can find him, okay.
Yeah.
But he's an absolutely talented person that have gone through difficulties and hardship because he tried to find a cheap solution for, and I see him as an idol for me because he's trying to find a cheap solution for people who lost limbs. We're giving them myoelectric prostheses from cheap 3D printers, okay, and making them available for these people that cannot pay the tens of thousands of dollars for this technology, okay? And he's a person that I would, put on a pedestal, basically, and he's an Australian hero, okay? But again, people attacked him simply because he's interfering with other people's business.
So, you mentioned that you've done something like 1,000 of these, and worldwide there've been 2,000. If you look in Iraq alone, you'll have to correct me if I get the numbers wrong, but I believe there's something like 200,000 amputees of that order from Iraq alone, and now we have in Ukraine, we have all landmine injuries all over Africa, and so one of the things that one direction you could go with this technology is you could build the Ferrari. You could go in the direction of having trying to get back full movement for every patient, or you could push in the direction of, let's see whether we can work with the supply chain. Let's see whether we can make this cheap. Let's see if we can bring this down so that you can do the operation in one procedure, maybe even in an environment which may exist in certain third world places. I'm thinking along the lines of what Fred Hollows did. He's also another Australian surgeon who bought lens implants all over the world. So do you have a plan for scaling? Do you have a plan for going into areas and being able to really, not just 1,000, this is impressive, of course, but do you have a plan for hitting these 200,000 Iraqis and the people coming out of Ukraine and other conflict zones?
So this is exactly my hope before I die. So we have a project that is going. In Iraq, it's well established. We have done 188 amputees in Iraq. All but one patient had been explanted. One patient had an explantation, and this patient, she will have a reimplantation the minute I go back.
Sorry, what does that mean, explantation? That's a failure?
The implant failed, and we had to remove it. She's still walking. Yeah. We put her back on the socket matter prosthesis, but because she was a child amputee and then she grew up to become an adult, and that implant, she was an adult when we operated on her, but she was a child amputee, so her bone was child bone. So it was very complex, and she will be reimplanted because despite that the implant failed, her bone grew. And now it's suitable for being fitted as an adult amputee if she wished to go with it. So all but that person, okay, have been successful and still are successful. Some people with some issues like discharge and things like that, but the project is well established in Iraq, and that will be scaled to be available to the wider public at a much cheaper price. Okay. Because I can't
how
keep.
Can you bring it down?
Well, it depends. It's a scale of volume. Okay, because I can't keep funding this project on the long run. So far, we have, similar to other projects in Cambodia, the 4 amputees that we've done are doing brilliantly well, despite what some people said. Okay, and I checked with them just in the last month, and they're all functioning very well, and they would not go back to the socket prosthesis. So in Cambodia, we want to go back. We've done a project in Lebanon, very successful. Israel, West Bank, Jordan, Egypt, Vietnam, India, Taiwan, Hong Kong. There are many countries that we've done projects in, and South Africa. Okay, and Ukraine, I'm going next week to start a project over there. The aim from every project is to achieve 3 goals. Number 1 is to help as many people as we can on the spot. Number 2 is to train the existing staff to manage these patients when we leave and continue to look after them. And number 3, to establish the base for these people to carry on and build the program further. Because I'm one person, okay, I have one team, and we can't achieve all of that. But we can have a multiplier effect by doing this, because philosophically the technology work. And philosophically, this is not, I'm the clinician and I'm managing these patients, and I have to manage every single patient. This is all about education, training, and handing over, and then people can carry on the process from there onward. Okay.
And how has the education in Iraq looked like? Do you have surgeons there that are? By the way, what's the infrastructure like there? When you go and do implantations there, what's it like in the hospital system? Is it developed again after the war?
So you have two different scenarios that we deal with. Okay. You have the Iraq scenario, and you have another scenario where you have struggling countries. Okay, so Iraq, before the craziness of Saddam Hussein, was very developed in the medical field. It went through the hurdles of ISIS and the American involvement, and then American leaving, and the turmoil of the looting and corruption of the government. But Iraq continued to have an infrastructure. So the infrastructure in Iraq is well established. I have 4 fellows. I have a current Iraqi fellow where they come in, they get trained, and they go back. I have visiting surgeons that come and go, and I have been to Iraq 8 times, and I'm going as soon as they send me the next invite, and they're coming hopefully a couple of months. And they have the facilities where it's built very well, similar to the facilities here in Sydney. There's no difference, okay? What they lack is the skills. What they lack is the experience. And that's where our job comes, where we can train these people and bring them up to the international standards. And we have done that. I continue to do that by getting the fellows coming in, training, spending 6 months to a year and going back, and by training the locals every time I go, and building the infrastructure from there. So Iraq is safe. Iraq patients are looked after very well. They're looked after very regularly. There is enough documentation, great deal of follow-up. Okay, Iraq is fine. Iraq standing on its own, and they are performing these surgeries by themselves now, without my need. We just send them the implants. Okay, so that is Iraq. Then you have other developing countries, which is a different area, like Cambodia is an example. Cambodia is a more risky area because in Cambodia the infrastructure is very weak. Okay, people live in more rural areas, and the government doesn't fund anything for the infrastructure. So it's a bit harder. Again, a language barrier for me is a problem. So I'm not saying that Cambodia is a hopeless case, but I'm saying that the challenge is much bigger. So that's why I did only 4 cases in Cambodia as a trial, and they still being managed. But on that smaller scale, we can manage it. But if we do hundreds in Cambodia, at this particular moment, we will fail. And we will put patients at risk. But Iraq, we can go on a significant scale, very easy, because the infrastructure is built, the staff are trained, and they are continuing to follow up with us, and they can carry the process themselves. Okay, so we are dealing with 2 different scenarios. There is a third scenario where you have the developed world, like the UK, Germany, Spain, Holland, Italy, all these countries we have performed. Israel, we have done cases in, okay, and very successfully. America, Canada, and they continue to do cases. And basically what we do, like I did the first NHS case funded by the NHS just last week. I came back from the UK. They invited me to go there. I did the training with the staff over there. We performed the surgery on the patient. Okay, they will follow them up, and this will open a window for the NHS patient from now onward, because they're well trained, they have the infrastructure, and they can carry on. Okay, so that's a different category of patients as well, where this is opening that technology for wider population of amputees, whether they are in developed countries or developing countries. And ultimately, by doing that and multiplying that, the scale of economy will be better, and this will become more acceptable practice, more standardized and cheaper for the broader population of amputees all around the world. So it is working. Obviously, there is a lot of opposition, and obviously there is a lot of criticism, which is important, because you need to be criticized. You need to be, as long as it's above the belt and it's not attacking the motive and the integrity. If it's a scientific criticism, absolutely. A robust criticism is very important to keep people at check, to make sure that the quality continue to be maintained and improved, and we all learn from our mistakes. So, but it's like with any innovative technology, the opposition is big at the beginning. It goes through phases. From what I've seen, you get ridiculed at the beginning, then you get attacked, and then you get attacked more fiercely, and then you attack more fiercely, and if you survive, people start coming and watching, and then coming and learning, and then people start taking it on.
And where on the curve are you at the moment, you'd say?
I think we are on the
downward.
The downward. Well, it's becoming acceptable, because I hope that the attacks are winding down, and because the technology does exist. I have the first patient I did was in 2009. He's still running. He's still going very well.
When you did that first patient, so right now you've got 1,000 patients behind you. You can show the numbers, but for that first patient, how do you get allowance to do that? What are the hoops you need to jump through?
So there are regulatory hoops. There are patient hoops, and there are personal hoops, because are you doing this to help the patient? So with regulatory hoops, that was easy because it was a trial that we started, and we've gone through the regulatory aspects of it without any problems. With the patient, I chose the patient, or the patient chose me, basically, very carefully. A patient was highly educated patient, well knowledge about the technology. He's a professor of biomechanical engineering. So he can't be better than that person. And he is very motivated. He was the flag bearer of the Sydney Paralympics in Australia, and he is a very reasonable person, very understanding person. And he researched it all over, and he wanted this to be done in Australia. Okay, so he was the best patient. We did the operation. Okay, and he wasn't the easiest patient from the technical point of view. It was very complicated.
And why was that, man?
From technicality, like with the bone. The bone was curved. I had to straighten the bone, and I had to do a couple of operations before embarking on osseointegration because the bone was not straight. We did the operation. We monitored the patient, that particular and that only patient, for a year. Okay, and we monitored him very closely, very carefully, making sure that every box is ticked. Once we were comfortable, the next year we did 3 patients. So we did these 3 patients, and we waited for a year for these patients while monitoring the first patient. First patient had 2 years follow-up. Second cohort had 1 year follow-up, and then we did another group. And then by the year 5 or 6, we were comfortable that we have 5-year follow-up of the first patient, and then we said, this technology work, now we can do it on a broader scale. Okay? And that's when we started saying that this technology does exist, please come if you want to have it. So we did not rush in doing hundreds in the first year and then fall on our head. Okay, we did 1, we did 3, and then we did, I think, another 5 or 6, and then from there it grew. So it was a very slow pace, very measured, very carefully assessed, and very well followed up. And I still follow him up to this day. And he's doing brilliantly well.
And how do you say the Australian medical, what would you call it, the fraternity, the system, is with regards to the balance between patient care and being conservative and approaching patients from the point of view of care and being innovative on the other hand? Do we get the balance right, or?
That's a very, very politically incorrect question. Look, I mean, Australia is a very conservative country. Okay, and sadly, we have a lot of talent. We have a lot of talented people, but we have a very conservative establishment. Whether for the right reason or not, that's a question. Okay. There's always need to have healthy checks and healthy balances in place, and healthy critical people that would come and criticize the work that the fraternity does. As long as it's done for the greater good for the patients. Okay. At the same time, the wheel of innovation need to continue. And unfortunately, there are certain few people around where they said it to my face. The wheel of medicine should have stopped in 1945. Okay? And it's not just osseointegration. When I first started doing anterior approach to the hip, I was extremely criticized about coming up with a new technology that's anterior approach to the hip, and this is new, this is dangerous, and it can't be right, because if it's right, why wouldn't we have done it a long time ago? Okay? And this is the wrong argument, because yes, it is a technology that has not been taking off because it wasn't the right time to take off. We didn't have the right instrumentation, we didn't have the right approach, we didn't have the right thinking about how it works, okay? Despite that, factually, they were incorrect, because its anterior approach to the hip is not a new technology. It was invented in 1924 by a Norwegian surgeon, Smith Peterson, in New York, basically. So it's not a new technology, it's an old technology, but it created a massive discussions and criticism in the orthopedic fraternity for a long period of time. And until now, there are surgeons who are strong believers that the anterior approach is wrong. Okay?
What is it exactly?
It's coming doing the hip replacement through the front.
I see.
Because the older generation do it through the side, which is a very invasive technique, and the vast majority of surgeons in the past do it through the back. Okay?
So you want to do it without severing muscles?
Well, the anterior approach is done without cutting any muscles, basically. It is more challenging technology, but I strongly believe that the best approach to the hip replacement is the approach that is done by the surgeon that know what they're doing, regardless whether it's anterior or posterior. I have my reservations about a lateral approach, but that's my personal view on it. But a good approach is an approach that is done well by the surgeon that know what they're doing, basically. So, but again, this approach was criticized very heavily by people, and unfortunately, people were vocal about it, despite that it is a well-established technology around the world. Okay, so we came late in adopting it, and now it's the most growing approach in Australia, basically. Same thing happened with robotic knee replacement. Okay, when we started doing robotic knee replacement, the criticism was that this is a gimmick and this is just a marketing tool. No, it's not. Robotic knee replacement does add significant value to doing a knee replacement. It gives extreme precision. It gives extreme view about areas that we can't see with naked eye.
By robotic knee replacement, you mean you are assisted in the operation by robots rather than the knee itself being robotic?
Yes, it is robotic assisted knee replacement where I have a robot in the room and the robot, so it doesn't start by the operation. The robotic knee replacement starts when the patient sit with you in the consult room. Okay, you take data, you take measures, and then you send them for special images, and these images, all the information get fed to the computer, and the computer analyzes it, and then this analysis is combined with what you take on the day inside the operation by guiding the robot through the navigation portals, and all this data get collected by the computer, analyzed, and then the computer spit out the details of where is this knee in space. And it's like a navigation, okay, of a plane where it tells you that Helsinki is in this part of Europe. Okay, you can't see Helsinki from here. Okay, but you know factually that when you take the plane that way, okay, you don't follow the stars. So I don't think there is negativity about the robotic knee technology. As a matter of fact, it's an added tool and instrumentation that will help you to provide a better service for your patient. But the criticism was that this is a gimmick, this is a marketing tool, this doesn't help anything, we can do the operation with our eyes closed. Well, with all due respect, okay, we need to be up to date with the science, with the medicine, and we need to adapt and accept change. And that is my criticism about some members of our fraternity. Change means the unknown, and the unknown must be bad.
So can I ask then, with this robotic assisted knee surgeries, for instance, what can you actually do so you said some people say they can do it with their eyes closed, or they find these surgeries simple, you don't need the robotic assistance. But in terms of the outcome for the patient, what can you do with these assisted techniques that you couldn't do before?
It's not about what you can do with it. It's about how accurate your measures are. And it's all about accuracy and of implementing your positioning of cuts and positioning of your implant. Because a knee joint is a structure in space that has multidimensional figure and can be put inaccurately in many planes, rotational wise, flexion extension wise, medialization, lateralization, size wise on the side plane and front plane, okay, depth wise with the joint line, okay, as well as angulation wise. So there is a lot of variables that go there. In order to restore a knee function, you need to restore 4 things. You need to restore ligament balance, and the ligament balance relies heavily on the position of the implant. You need to restore the joint line, you need to put it in the right space, not high, not low, and that relies heavily on how you measure where to put it. You need to restore the patella tracking, and that relies heavily on the rotation of the implant. If you rotate it 1 degree here, 1 degree here, and you need to restore basically mechanical access. Okay, and that relies again on how you put it in line wise. So a knee replacement is not just whacking the cartilage off and putting a piece of metal in. A knee replacement relies on accuracy and how you position the implant in space in a precise manner. If you get it wrong, majority of unhappy patients with knee replacement is simply because the patella tracking is not good. Simply because they got stiff, because it was overstuffed, simply because the size wasn't right. Or often, is because of a combination of a lot of these things. Okay, so you need to take into consideration that every patient comes to your room is the only patient that you're treating, and give them the best of your ability with knowledge and whatever you have in your armamentarium to supply them with. So I don't see any negativity in utilizing good technology as long as you are familiar with it, you know how to use it, and it's for the best interest of the patient. And the data from our registry, and the registry is a very good example about the results, because it's a blunt tool. It collects data from every surgeon in Australia, and then it compare them with each other. Okay? And you can't lie about that, because it's a national registry and it's collecting these data and it's spitting out this information, that tells you where you are and where you stand, and you know if you're performing or not. Because everyone can tell you that I'm the best surgeon in the world. But the data, bluntly, though it's a blunt tool, it can put you where you are in the performance. And the data have showed clearly that people who are using assistive technologies such as robotic, the results are coming superior. Okay? But can I say that the robotic technology better? No, I can't, because I'm just going by what the data is showing.
Do you, this is going to be a strange question to ask someone who's doing this as a profession, but do you still have moments where you are in the operating room and it just seems crazy that your job is opening up, that you have full trust from this person, it's sort of, it blows my mind that we can even do this. It's normalized. It happens every day, but it's really amazing that we're able to do this.
Look, I may never said that before, but every patient I operate on, it takes me a couple of seconds before I enter the room. I think to myself that I should give this patient the best of my ability. And I have to always remember that I need to respect what I'm going to do and respect what I'm dealing with. And almost every single case I do, when I open, I say to myself, holy shit. Okay. Sorry, I swore.
That's okay.
Okay. But it is a big responsibility. And I don't take that lightly. And we can laugh, we can joke, we can say stupid things sometimes, but it remains, when we do our job, we do it with the utmost respect toward who we're dealing with, and try our best to give them the best, to the best of our knowledge. And again, I want to continue doing that. I don't want my job to be a business or a job like any other job, because I chose to do medicine because I love helping people. Okay, and unfortunately, I've been told again and again and again that it's just a job like any other job, and you just need to treat it like any other job, and you should stop giving your number to your patients, because if you miss a phone call, they can use it against you. And this is not what medicine is about. It's about trust, it's about helping others, and it's about with open arms, try to be kind to people, and not to expect anything in return.
So then I'm going to direct the conversation towards, I want to sort of end off with a word about the future and sort of your dreams for the direction of this field. So I'm wondering, Is there any technology or any advancement that's currently happening that you're particularly excited about in the field? Is there something that really you think is amazing that's happening right now?
Look, I think what I was embarking on just recently was to take osseointegration to the next level. Mm-hmm. And that is by combining the targeted muscle reinnervation with implantable electrodes devices where you can operate a myoelectric prosthesis. And this is a big project. This is the next level where you stabilize the prosthesis by skeletally attaching it. You hooked up the nerves and reorganize them, and now you need to connect the nerves and make them operate the prosthesis. And this is the next generation. Okay. There are many things that I'm working on to solve existing problems like infection. Okay. We are in the process of developing an antibiotic emitting implant, okay, that kills the bacteria locally without causing harm to the body. Negatively charged implants that would repel bacteria basically and prevent the bacteria from forming a biofilm around the implant. Okay. There is another technique where I'm not in the business of trying to monitor people, but we are in the process of developing an implant that can self-sense, okay, and count the steps, count the stresses, and detect whether they are impending fractures or at risk of failure. Okay, and a smart implant that can tell us and feed to us basically information about what it's doing. Okay, so there are different avenues. One is functionality and improving functionality. The other is prevention and limiting and reducing infection. The other one is self-detecting and self-awareness implant. Okay, all of these areas I'm working on. Some of these projects will see the light before I finish my medical career. Some of the projects will continue. Okay, but it's very exciting, and we are look, I strongly believe that the day will come before I die that this technology will be available to people who need it most, people who cannot afford it, people who live on $1 a day. Okay, that's the main goal, is to make it available to the masses, and then the cream comes with these technologies that can help okay, and add value to the technology that is already existing. And then ultimately, well, what my bigger goal is that, because osseointegration is a small part of my portfolio. I'm a hip and knee surgeon, and I do hip, knee, ankle replacements. Okay, and that's what generate the income for me and make me, pay my bills and pay the project that I go with, osseointegration. Well, until recently, because now osseointegration is standing on its own feet. But ultimately, what I want our health system in Australia to be sustainable, because we are on the brink of collapse in the health system in Australia. We have an ailing public sector that is drowning, and we have a private sector that's struggling with inflation of basically premiums that patients are suffering from. There are ways of making it sustainable. There are ways of working on, which is patient-centric, cutting the unnecessary extra costs, and improving the quality of care for our patients, and maintaining the balance and the equilibrium in our health sector without adding premiums to patients, because it disheartened me to see that patients are not able to afford their insurance and dropping off because simply it's becoming too expensive, and it's not necessary. It shouldn't be like that.
So what can be done? What are some realistic steps that can be taken right now to improve the medical system in Australia, in your mind?
I think we have a problem in Australia with the way look, this is way bigger than me, this problem, and but I have some ideas. Like, I work in the private sector, and I can see what's happening in the private sector, especially in arthroplasty. A lot of patients are unnecessarily going to inpatient rehabilitation. Okay, and that's a massive, what people don't realize, by them going to inpatient rehabilitation, if it's not necessary, if it's not indicated, they are increasing their premiums dramatically, because every day in rehab it costs nearly $1,000 or more. Okay, if they stay 10 days, that's $10,000 added to the cost of their surgery, which is costing their insurer and costing them basically another $30,000. Okay, so added to that, then you inflate the price of a hip replacement or a knee replacement by another 10, 15, 20,000, okay, that are not necessary, that can be managed much more efficiently, much healthier if they are not indicated for it, okay, by being managed as an outpatient rehab or as a home rehab. Okay, the best place for a person to recover after surgery is their own home environment. They're familiar with it. They can it's less chance of infection, less chance of being exposed to unnecessary risks of falls and fractures because of the familiarity with their surrounding. And at the same time, okay, it costs significantly, a cost and a burden on their insurer, which will be translated a burden on them by paying their premium. So it's a cycle.
Yeah.
But we need to break that cycle. We need to think about, where is this money coming from? Okay, and that's why we are embarking on building institutes and organizations where it will be patient-centric, no out-of-pocket expenses. It disheartened me when I see a patient coming to me, sitting in front of me, and they are in desperate need of a knee replacement, and they put it off for so many years because they couldn't afford the out-of-pocket expenses, because they've been to Dr. So and Dr. So, and they were asked to an extra amount of money. And they say, how much do you charge out of pocket? And I say, nothing. I would not charge you anything out of pocket. Okay, and because ultimately we need to treat this, and I will take whatever their insurance pay.
Are you able to say a few words about what you're actually creating now in terms of the hospital you're building, or?
So we're building a joint replacement center on top of Macquarie University at the moment. This is a nucleus for a new change in the health sector. It is patient-centric. It will be arthroplasty center where joint replacement are performed, hip replacement, knee replacement, ankle replacement and shoulder replacement are performed, and hopefully the aim of that is to provide this with collaboration with insurers, okay, that there will be no out-of-pocket expenses for the patient. Rapid rehabilitation program, rapid recovery, and outpatient physiotherapy, where the patient can receive their physical therapy and rehabilitation at home. Okay, and cutting the costs for the patient by not having any out-of-pocket expenses, which is a big deal for a lot of our aging population. Okay, because when the last thing the patient, when they become at a pensioner's age or a retiree, that they have to pay $3,000 or $4,000 out of pocket, okay, for every joint they replace.
So, but how do you make this lucrative for what's the mechanism that you use to make this lucrative for the insurer, but also work for the patient? So what's being done that's different?
So what's done different, I wouldn't use the term lucrative for the insurer. This process is trying to cut the bleed and reduce the damage. It's a damage control rather than more money generating project. Because the premiums are going up, as a result of the premiums going up, a lot of people are dropping out. And people who are dropping out are the younger population who think, I don't need a joint replacement, so I'll drop out of insurance. And people who cannot drop out are people who need joint replacement because they can't afford to drop out, because they don't want to go on the waiting list in the public sector.
But they're also the expensive patient.
And they are the expensive patients. So the person who's the people who are struggling are the insurers, and then they bounce that back by increasing premiums. So it's a vicious cycle that's inflating the prices of insurance dramatically, and is generated by simply management issue of our health sector. A lot of patients come to the clinician and they say, I need a knee replacement, but I want to stay for 2 weeks in rehab because I just want to stay away from home. And in rehab, they feed me, and they look after me. What the patient is missing out on, number one, is that inpatient rehab, if it's not indicated, okay, it will not add any benefit to their recovery. Okay, it can increase risks. Obviously, patients who are properly suitable for inpatient rehab are patients who are clinically indicated to go to rehab if they are at risk, if they need inpatient rehab, but not as a choice. Not the patients who choose it as because it's just it's available for you. That's not the right indication for rehab. And this bed will be occupied by a person who may not need that bed, while another person is waiting to have this bed, to need it. Added to that, this cost is coming out of this patient pocket, ultimately, because they will be paying for it by their premiums. So if it's not necessary to stay as an inpatient rehab, if it's not necessarily to stay 7 days in the hospital, we started a pilot study by optimizing prehabilitation, optimizing patients for the surgery, and optimizing the care of the patient, and just tweaking out the anesthetics and tweaking out the physiotherapy protocols and tweaking out the pain management protocol for these patients. We dropped the hospital stay after a joint replacement from 8 days to nearly 3 days now. This is a dramatic improvement in the outcomes for patients, because patients are mobilizing earlier. Instead of the patient staying in bed for 2 days after the surgery, we get the patient 2 hours after the surgery, once the anesthetic is wearing out. Okay, and by doing that, if you mobilize the patient as early as in the day zero of the surgery, you reduce the risk of clots in the leg, clots in the lung. You save the patient basically from having cramps and spasms and swelling. By mobilizing them, you reduce the swelling in the leg. By mobilizing them, you encourage the circulation, reduce the chance of infection, you reduce the chance of developing consolidation in the lung, heart problems, and you get them healthier. And at the same time, you get them quicker out of the acute center, less chance of contracting an infection from the hospital, and returning them back to their normal home environment. At the same time, you cut their costs, ultimately. So it's a win-win situation for the patient, ultimately, better for the patient, and secondly, for their pockets.
Why isn't this being done? Why are there obstructions in place?
Sadly to say, it's been done all around the world, and we are late to adopt it.
I see. So this is a proven path.
We are not reinventing the wheel. We're not creating a new trend. We are just trying to catch up with the rest of the world. And I hate to say that. This is the sad reality about our system. We are not doing anything different than any other well-developed country has done 20 years ago.
So let me end then by asking you, imagine I'm a young 18, 19-year-old kid who wants to go into becoming a surgeon, who wants to go into medicine. Do you have any advice for what they should be studying, what they should be doing? What's your advice for a young person who wants to become a surgeon, up and coming?
My advice to anyone who wants to become a surgeon is to have faith in what you believe in, and be humble. Humility is very important. You are a human being like any other human being. You're not superior to anyone. You're not more privileged than anybody else. And accept criticism with open arms and with open mind, and use it to improve your work and your standards, and ultimately realize that whatever you do, you are here to serve your patients. It is a very difficult job. It is a very rocky road, okay? It's not a job that will be financially rewarding as much as you think so, because if you want to have money, do something else, because you'll spend all your life, even if you make that money, you will not spend it, because you spend all your life in theaters. And it's not a job for someone who want to have, unfortunately, it's not a good job for someone to have, a job on the side and then my life. It's a full commitment. And you need to be dedicated for it. It cannot be half-cooked. It needs to be done. It needs to be done well.
Do you love your life in surgery? Do you?
Look, what I do is very rewarding, and you have great rewards from the happy patients, and you feel very humbled when you see bad outcomes and complications. But then, you take it on the chin and you try to improve, you try to fix the problem, and you try to do your best the next time, okay? And even though a lot of the time it's out of your control, but you have to take responsibility for everything. And that is another thing that is about our career and our profession. A lot of the time, things go wrong not because you've done something wrong. Things go wrong because it did go wrong, okay? And it's beyond anyone's control. And that's the worst part of our profession, is that a lot of the time it can be outside my control, but things didn't go the way we want it to go. But you have to take full responsibility on it, you have to cop it, and you have to deal with it.
Do you think this is an odd question to ask, but do you think your time as a refugee and being held in detention had utility in that regards? Because everything was out of your control at that point. It was out of your hands, but you somehow bubbled up, and you're in Australia, you're a representative for refugee rights, you've done time in the Air Force Reserves, you're a very successful surgeon, you're helping people. Do you think there was utility and you became a more resilient person, or?
Look, we are who we are by the experience that we've gone through. And diamonds become diamonds because they go under enormous amount of pressure. Definitely I was not the same person before the moment I faced the Republican Guards. I was a completely different person, had completely different prospect to life. But I can tell you for sure, I was brought up to be resilient. I was brought up, despite that I come from a very well-off family, and I had to work hard to get what I want to get. I think my parents, especially my father, have put the right seeds in me, and it's always a combination from nature and nurture, basically, to become who we are. Ultimately, I'm still learning, and life keep going, and I will continue to learn till the day I die.
Well, Munjed, it's been an absolute pleasure having you on the podcast. Thanks for coming along.
Thanks for having me, and thanks for spending time with me.